very much. I'd like to thank the organizers and Marwan, who's a good friend and colleague, for the invitation to speak at the second annual Houston Shock Symposium on this topic of low flow and hypotension following LVAD implantation. My disclosures. So, as with everything we do in medicine, it really gets down to diagnosing the problem. We've heard already throughout the day about diagnosing the problem quickly and early in the setting of disease. And this is an algorithm that was put forth by Dr. Feldman in an early statement as it relates to the approach of monitoring and evaluating a patient with low pump flow following LVAD implantation. I'm sure it's review for most in the room, but in the early postoperative period, the things that we're thinking most about are hypovolemia, namely due to hemorrhage. Also worried about tamponade and bleeding into the pericardial space. So this is a patient that we had, and you can see a large pericardial effusion with complete collapse of the right ventricle, which of course is going to lead to a low flow state. And then we'll talk more about right heart failure, which we've heard a lot about already. Less commonly is inflow cannula obstruction, although I have seen that. And in fact, this is a case of a patient who had persistent low flow due to a large muscular band in the left ventricle, and he required going back to the operating room on post-op day 1 or 2 for resection of that band. And I have seen a patient as well have kinking of the outflow graft, requiring return to the OR within the first week of surgery as well. So you know this. I mean, we've talked all day about the importance of allowing the data from our Swan-Ganz catheters and right heart cath to really guide clinical decision-making and to nail this diagnosis, to figure out what the problem is. But we need to avoid paralysis by analysis and understanding that there's lots of places where you can get erroneous data, both in the acquisition as well as in the interpretation. So if things aren't adding up in our patients, if we have a patient who's persistently hypotensive, high doses of pressors, it looks like they're in right heart failure, but the right atrial pressure is 6, you need to be at the bedside because there may be mistakes that are occurring, and you need to really put everything together and within the clinical context of that patient to make an informed decision about where to go next. One of the things that's been really integral to the growth and development of our program is the building of our cardiac intensivist program. So we now co-staff all of these patients with a dedicated cardiac intensivist, the cardiothoracic surgeon, as well as the heart failure cardiologist. And the intensivists are present. They're at the bedside throughout the course of the day to really, again, do just that, to monitor these hemodynamic data and to nail that diagnosis early so we can take the next steps when appropriate. There are data. These are data from Japan looking at the impact of a cardiac intensivist program. This is not an LVAD population, but nonetheless, I think the analogy holds true, and they demonstrated that following development of this program, that there was a reduction both in ICU as well as in hospital mortality. This is not rocket science, I'm sure you're aware of this, but bleeding is bad. And these patients come out of the operating room and they're coagulopathic for a number of reasons. And both the bleeding itself, which can lead to hypotension, as well as the resuscitative efforts, can have deleterious impacts on our patients. So with the resuscitation, we can see further distension of the right ventricle. We can, of course, lead to transfusion-related lung injuries and worsening hypoxia. And we need to ask, is the bleeding surgical or is it coagulopathic? And we need to move quickly with our surgical colleagues to correct the underlying abnormalities. Again, this is another place where our intensivists are really important because they know much better than I do as a cardiologist how to take care of the lungs. And managing a patient's pulmonary function is really critically important in the early postoperative period. Because if we have a right ventricle that's myopathic and struggling, in other areas of cardiac surgery, there's often a push for early extubation protocols, and there's some good data about reducing morbidity when we get patients extubated early. But those trials did not include our patients who are undergoing VAD or transplant procedures. And if we extubate someone prematurely and they really struggle from a respiratory standpoint, that hypoxia and the acidosis that could ensue is going to set up our RV for acute failure. This is another friend, Jason Katz, who directs the cardiac shock program as well as the cardiovascular ICUs at UNC, and he provided me a few of these slides, and these are his words of wisdom. We heard a little about this earlier, but in the very early hours following cardiac surgery, these patients are vasoplegic, and they have a SIRS-like syndrome with capillary leak, and there's third spacing off into the pleural cavity. and you have to aggressively fluid resuscitate these patients in those early hours. However, over the ensuing hours, things evolve, things change. We see improvement in vascular tone, mobilization of the fluid from the extravascular space back into the intravascular space, and we see rise in intracardiac pressures. And again, we see distension of the RV, worsening right heart failure, which is going to lead to impaired LVAD filling, low flows, hypotension, and worse than that, the cardio and hepatic syndromes, worsening renal function, et cetera, when the RV really starts to fail. Right heart failure remains, unfortunately, really common, even in the contemporary era. So in the most recent clinical trial, the Momentum HeartMate 3 trial, we see severe right heart failure, defined as the need for prolonged inotropes, or RVAD, is still over 30%, mostly driven by prolonged inotropes, but still very common. And of course, we know from INTERMACS that right heart failure is really the leading cause of early morbidity, mortality, the leading cause of death in the early postoperative period. So as it relates to the goals of treatment, we've heard it time and time again in the management of shock. It's early recognition, early resuscitation, maximizing perfusion of the RV, avoiding hypotension to avoid ischemia of the right ventricle, inotropic support to maintain end organ perfusion and function, decrease in RV afterload if there's evidence of elevated PVR. So these data look at the impact of inhaled nitric oxide and patients undergoing LVAD surgery, and you can see a reduction in mean pulmonary artery pressures as well as augmentation of LVAD flow index. We've talked about the need to reduce preload and use CVVH aggressively if patients are not responding to diuretic therapies, and then importantly, treating atrial arrhythmias. The myopathic and struggling RV does not tolerate atrial tachyarrhythmias very well, and oftentimes these patients need to be cardioverted. You need to be aware of LVAD-RVAD interactions. Of course, implanting an LV impacts both the free wall contractile patterns as well as the septum contractile patterns, which can directly impair RV function, and we need to do optimization studies to ensure that the LV is not overly unloaded. Don't wait to support. Again, time and time again, and these are data from Penn from a while ago, but we see that delay in BiVAD support can lead to dramatic reductions in survival to transplantation compared to a planned BiVAD strategy. And we have a lot more and more tools to support these patients. And then finally, what is the role of oral vasodilator therapy for the prevention of early right heart failure? Some of you may not have seen these data. Hopefully they'll be published soon. We presented previously at the ISHLT, and Eddie was part of this analysis. But we tried to look at the role of PDE5 inhibitors for preventing postoperative right heart failure. Despite attempting to adjust for baseline confounding variables, we did not find that PDE5 inhibitors such as sildenafil reduced the risk of right heart failure. In fact, these patients tended to do worse, and they also had increased rates of other adverse events such as bleeding. So there really doesn't appear to be a strong evidence, there's really no evidence to use things like sildenafil for prevention of right heart failure. And then lastly, this is my last slide, be prepared. We should all be, and I'm sure you are aware of the high-risk patients, but you need to be familiar with the hemodynamic profiles as well as the biochemical profiles of these patients. But most important is really the clinical profile, right? So it's those INTERMACS patient 2s who are failing multiple doses of inotropes, escalating vasopressor therapies, or importantly, if they're failing temporary mechanical support, that's the highest risk patient, and you need to be prepared to support them immediately following LVAD implantation if there's evidence that they're struggling. Thank you.
Any questions?
Covered it all.
Vasopressor use in RV failure, there's always a debate about hypotension and RV
Microphone, please,
failure.
for her, that everybody can hear. Thank you.
Worsening hypotension and worsening RV failure. So what do you use as the ideal vasopressor agent without increasing PVR?
Yeah, I mean, clearly there's not a lot of data to guide that decision. I mean, our routine is go-to is epinephrine early as well as norepinephrine. From a cost perspective, the third agent would be vasopressin, but administrators monitor the cost of postoperative drugs, but we would use a lot of epi as well as norepi to maintain blood pressure. Being aware, we have milrinone on for support. Of course, milrinone's a vasodilator, so if their kidney function is struggling, then oftentimes I'm telling my surgeons that we need to back off in the milrinone because that could be, causing additional vasodilation and promoting that hypotension that's affecting the right heart function.
From the practical standpoint, if you have a patient now coming from Zoar in 2-3 hours, started to have low blood pressure, low flow, and have low flow alarm, what's your diagnostic steps? How you are approaching this patient?
So I'm sorry,
To get
again,
the differential diagnosis. It might be, as you mentioned, there's many things could happen here. You have tamponade, you have right heart failure, you have hypovolemia. How you are going to make the diagnosis? Can you tell us the practical steps you're doing in
this is still, you're saying the early postoperative period
Yes,
coming out of the
yes.
OR? Yeah, I mean,
2 hours from Zohar now, and he's coming, and he's came with norepinephrine, Primacor, and he started to came with 5 liter. Now he's started 2.5 liter. How you are going to teach and to say how we are going to approach this patient?
yeah, I mean, we're calling our sonographer, and if it's after hours, our fellow to make sure the echo probe is set up at the bedside, ready to go. And then, you know, all of these patients are coming out of the operating room with a Swan-Ganz catheter in place. So we're making sure they're being appropriately leveled. So again, that we're getting accurate data from the hemodynamic waveforms, looking at those directly and not taking, you know, our nurses in the CTU are fabulous, but sometimes we have less experienced nurses. And like I said, if things aren't adding up, you got to get the data yourself sometimes. But it's really, I think it's driven by overall clinical picture, what the patient looks like. You have to be laying eyes on them, hemodynamic data, and the echo to make sure you're not missing an effusion. What does the RV look like?
That means the hemodynamics and echo is important to get the diagnosis.
They're critically important.
Yes.
I mean, it's based on both of those,
Yeah.
yeah.
I think one of the more difficult things for us in the LVAD world is to predict who's going to have RV dysfunction. And you have a patient with RV going on that is in trouble, you can predict that this patient is going to have some type of mechanical support. But what happened with the patient, because it also happened that comes to the OR with an RV that all of us think is going to do well, and then it's not doing well, and you know that from the OR to the get-go. What is your threshold to start mechanical support on those patients in the OR? Or what do you think is early enough after the OR to put those patients? Is a time frame that we need to be aware of, or we'll just let the patient go? And on the sildenafil, I think the other thing, the problem is, for RV dysfunction, could be 2 problems. One is a resistance problem, which is an inotropic problem. So PDA5s or INO and nitric oxide are not going to be good if there's no resistance problem. It's a problem with inotropic effect. From the PAH world, we like vasopressin a lot because we believe vasopressin has also a vasodilatory effect on the pulmonary arteries. So I think I will say vasopressin will be one of the ideal ones to use when you use need pressure for those patients.
Yeah, I mean, so there's certainly data too that vasopressin may have some beneficial effects on renal perfusion and improving renal function and urine output in patients with vasoplegia following cardiac surgery. So that was the last thing you mentioned. What's the trigger? Well, you know, I'm not in the operating room, but obviously it's markers of perfusion, you know. So and it's really that heart team approach with the surgeon. So it's really challenging, I think, as a team and the patients that we think are going to do great and when they're not. And sometimes I feel like there's a lot of institutional inertia and team inertia overcome to support those patients mechanically. And oftentimes those patients do get flogged with inotropes for a number of hours, monitoring very closely. And again, if that RV is not turning around within hours, not days, then that patient needs to go back to the operating room and be supported mechanically. But it's markers of end organ perfusion. So everything else we've just talked about across the day with shock as it relates to lactate, urine output. I mean, urine output's a big one, obviously. And then what the hemodynamics are doing. If they're a persistent low flow state by their fit cardiac index and their pressures are high, then meaning right atrial pressure, right-sided pressures, they need to go back.
We have in Integris, we're having that approach, I think, is not a bad thing. Let's see, an unpredicted right heart failure in the operating room. Now, patient we will not predict him to have severe right heart failure and have difficult weaning from bypass. The surgeon are calling the cardiologist and intensivist, going downstairs to the operating room, analyzing the patient and to see what we can do for this patient. And we're doing that for the patient post-transplant, if we have problem with that, and patient who requiring unanticipated RVAD support in the operating room. And we'll try to stay low with the threshold of inotropes, not to go high with inotropes. It's killing patients.
Yeah, patients often, I mean, we have a low threshold to keep the chest open as well, to allow easy access if we're going back to the operating room. The other thing you had mentioned was the role of inhaled or vasodilator therapy as well. I couldn't agree more. I could say that honestly, our institution, we're using Velitri, inhaled epoprostenol, like it's oxygen on every patient now, and it's really delayed care. If we're not using it only in the presence of evidence of elevated PVR. It's just being put on everybody, and I think it's honestly delayed progression of care at times and progressing it and getting patients out of the ICU in an earlier fashion.
Hey, Mike. Yeah, great talk. I was just wondering what's the approach at Tufts in patients that, again, are intermax 2 on high doses of inotropes. Is there a tendency now to utilize temporary mechanical support to try to minimize the inotropes? Like, for example, I don't know, a patient with dilated cardiomyopathy going in on milrinone 0.7 versus saying, let's just put either a contrapulsation or, Impella to try to minimize that, and also perhaps minimize PA pressures coming in, et cetera.
Yeah, I mean, there's no question we're trying to optimize patients in advance. We are high utilizers of the Impella 5.0 device, and sometimes that's a good test to the system. I mean, you're getting 5 liters of support, so if you have 5 liters in and you're able to wean inotropes, and you're much more comfortable that, a durable surgical LVAD is going to be enough, because those are patients that I'm really concerned about how well they're going to do with univentricular support alone, and we've had great experience with that.
I have one. Actually, for Maria's point, we know when it's time for the RVAD, but one of the struggles is also, is it going to be a surgical approach, is it percutaneous approach, or when is the term converted to the permanent RVAD? Like that's sometimes they recover so quick, sometimes it takes time. Is it keeping the chest open that long in surgical way? And that's one of the struggles that we deal.
Yeah, so we're using Centromag primarily as our device of choice for treating acute severe right heart failure with the attempts to wean these patients back to univentricular support. Given, as you know, that we don't have great long-term options with continuous flow devices. We are not a TAH program, so we don't have that luxury. We do have experience with implanting some of the continuous flows bilaterally and converting from Centromag. But obviously now, with the if they're a transplant candidate, the change in the UNOS allocation policy does advantage that patient, meaning if they have severe profound right heart failure and then a Centromag, that's someone, I'm in region 1 a year ago, it would have taken me 9 to 12 months to get a patient like that transplanted. Now I can reasonably get that patient transplanted within a couple of weeks. So it has done, I think, what it's intended to do for those high-risk patients.